palliative care.
Well, good morning and welcome to Palliative Care and Geriatrics Grand Rounds. As always, welcome to all of those here in the Ether Dome, those at Dana-Farber, Care Dimensions, and Cooley Dickinson. We're a large virtual family. I'm B.R. Dobman, I'm the course director, and it's my privilege today to introduce our guest speaker this morning. Dr. Fabian Johnston is an associate professor in the Department of Surgery at Johns Hopkins University, where he also serves as the chief of the section of gastrointestinal oncology and sarcoma, director of the peritoneal surface malignancy program, and associate program director of the complex general surgical oncology program. Dr. Johnston received his undergraduate degree from the State University of New York at Stony Brook and his medical degree from the Pennsylvania State University College of Medicine. He completed residencies between the Louisiana State University School of Medicine and Washington University in St. Louis. He completed his complex general surgical oncology fellowship at the Johns Hopkins University. He also earned a master's in health sciences at the Bloomberg School of Public Health and a certificate in patient safety and quality through the Armstrong Institute for Patient Safety and Quality. He is funded through the Agency for Healthcare Research and Quality with Patient-Centered Outcomes Research KO8 Career Award. Dr. Johnston's research interests include utilization of novel strategies for the implementation of patient-centered models of care to improve utilization of palliative care amongst patients with advanced gastrointestinal malignancies. Through this, he hopes to advance effective palliative care to lessen suffering in the vulnerable oncology patients and their families, while simultaneously leading improvement of healthcare quality, cost, experiences, and outcomes. Please join me in welcoming Dr. Johnston.
Well, thank you, everybody, and thank you for this invitation and the opportunity to be at man's greatest hospital. Don't tell my Hopkins colleagues that I said that. That's what some people paid me to say. I'm really excited to be here. My only disclosure is, while I'm not a palliative care doctor, I am a groupie, and wholeheartedly a groupie, and so it's my passion in life. I just couldn't do another fellowship. I thought my wife would have divorced me, it would have gotten awkward. So today, we're gonna kind of weave a narrative through kind of how I've gotten to where I am today, hopefully ending up talking a little bit about what my future R1 submission is going to be. And, you know, I titled this talk, D&I, Dissemination Research and Palliative Care, and we'll talk about that, but how do we get back to the future? You know, kind of when I look at this, I think of where we used to care a lot more about how do we take care of patients as a whole, but as the medical system has gotten more technologically advanced, and I know Jennifer Temmel wrote a nice paper in JCO about immunotherapies and still focusing on palliative care earlier this year, but we've gotten away from that. And I'm a big Back to the Future fan. Some of you may or may not like the movie, but I took a few slides out because my friend of mine said, nobody's going to know what you're talking about. And so some people will, some people won't. So we'll have a few breaks in the middle. But hopefully we can get to how do we get back to this future of taking care of these patients who are quite vulnerable. So objective is to define D&I research, a little bit more about healthcare quality, understand the role of D&I research in improving sustainability of change, and recognize that every system is designed to achieve the results that it gets. So where are we now? So here we go, right? It's the trilogy, right? The greatest trilogy ever made. The Godfather fell off in the last one, right? But you cannot lose with Back to the Future, I think. So I don't need to tell this audience much about this, right? There's an increasing need for palliative care. Our population continues to age. The prevalence of cancer as that population continues to age will continue to go up. And so with that, we know that there's going to be a strong need for palliative care. When we think about that, we have evidence-based care. So at the base of what we have, when you're looking at dissemination and implementation research, you have to say, do we have an evidence base to go off? And you know, there are multiple clinical trials here that have shown effectiveness. And when I talk about this always, you know, when we look at the Temmel study, which is really what got me into this, I said if this, you know, being one going surgical oncology, if this was a drug, this would be $1 billion industry, right? But somehow we haven't gotten there. We have endorsements from everyone who matters, right? But yet we still haven't found a way to translate that into more practical utilization. When we think about this, this is really quality care, right? We talk about this. I think we don't always scope it that way. But when we think about palliative care, we think about how does the Institute of Medicine define quality? And I think that palliative care fits all this, right? So is it safe? I think that's something we can't argue. Hopefully we can get this something that's timely, right? So timeliness is very important. Effectiveness is unquestioned. Is it efficient? Absolutely. If you have palliative care, you're more likely to obtain the care that you need. Equitable is something that I'm going to be talking about more, but once we have enough studies now that have shown that once patients get palliative care, the disparities in care that are may have occurred previously have dissipated, and it's clearly patient-centered care. For me, it's important because minority populations continue to grow, right? And so within the next 20 years, it's estimated that minorities will become the majority of the US population. As you can see here, the rate of African Americans, Hispanics, Native Americans, which are often an under-discussed group of individuals, and Asians continue to grow. And even within that, my friends, I spent a lot of time in San Francisco this summer, and when I've talked about this, people always try and lump Asians together, which is such, you know, I mean, we don't want to be an African Americans a monolith. We really are trying to make Asians a monolith. They really are very different cultures and backgrounds. And so the factors that affect the choices of these individuals are influenced by these cultural beliefs, right? Everyone has their different culture that is prevalent and affects their choices. And when we think about this, this plays in a major way on patient and physician communication, their decisional control preferences, right? Abuela may not be the person that's making a decision. It may be the family that's making the decision for Abuela. Cultural attitudes towards end of life are prevalent. And when on top of this, we're also now bringing people with advanced diseases, right? So we're not talking about diabetes. We're talking about cancer, and I'm a cancer doctor. And so now when we really think about this largely, all of this is under the scope of we are not providing much palliative care. So this is a paper that we published earlier this year looking at just inpatient use of palliative care, because one of the issues that we have is we have great institutional evidence of poor utilization. And often we're talking about outpatient, but the gap is in the inpatient utilization. And we see here the rate of palliative care utilization for basically all solid organ malignancies is really low, right? So we take an APR DRG. These are people that have a high risk of morbidity and mortality in the hospital, and the rate of palliative care utilization in those patients is very low. Underlying all this, and I'm not going to go deep into it because there's no point, right? Everybody and everything, we will find a racial and ethnic disparity. And so the manifestations of that disparity is that there's lower quality of care. So when we think about pain is something that I think about a lot. And we looked at this, that there's low pain assessment. So there's, in the popular media right now, it's talking about African-American women dying in pregnancy higher, right? That's because the assessment's not just pain, the assessments are lower. The treatment is lower, the access. There are studies that have shown that there are lower numbers of pharmacies in African-American areas, and the amount of narcotics that are available in those areas are even lower. So we're not providing the care from a policy, from a public planning way, in a way that should be equitable. There's less satisfaction. Again, it brings us back to this quality of communication. There's another article in the New York Times that we're not even talking about cancer. African-American men are more likely to follow evidence-based care if they have an African-American doctor. Right? And this is data that's going back 30 years, actually, that's showing that majority populations are less likely to spend the time with their patients in order to have them just shooting the breeze, in order to have them feel grounded and following these decisions. Is the provider listening and sharing? Again, going back to this communication. And so this often can lead to this racially discordant relationship. And what this leads to is lower rates of hospice use amongst minority older adults. But at the end of it, we also realize that we have a lot of information about hospice. We have administrative data sets. We don't have a lot of information specifically about palliative care. But what we do know is that when palliative care is used, favorable outcomes occur. So what's the problem, right? You know, we've got effective evidence-based medicine. It's not utilized. Well, there are a lot of implementation challenges, right? So we all know this, so I'm not even going to spend too much time here. We know that there's misperceptions, bias towards active treatment. There is a lack of not enough workforce, right? So that's a major thing that underlies where my work has went in terms of the workforce shortage. There's a mistrust of the healthcare system. So I am sure that every major health system in every major city has a legacy of discriminations of minorities in their communities, right? It doesn't matter, anywhere I've been in this country, from New Orleans, St. Louis, Baltimore, these great hospitals, there's a legacy that's there. And so that often leads to minority patients, or specifically African-American patients, actually demanding more care that may or may not be consistent with their goals because they're afraid that something is being withheld from them, right? And so this is something that we need to be cognizant of when we're planning the social underpinnings of decision-making that goes on. And often we walk into a room and we forget all the things that are going on. And that's what palliative care does though, right? We're not thinking about just the disease, we're thinking about the whole patient. But we also have to recognize this as palliative care clinicians when we go into a room. So there's a quality gap. We've discussed this. Where palliative care is not the only folks that are in the room looking at this. So when we look at percentage of patients receiving recommended care, this is low across the board. And we're also seeing that the issue is underpinning this is an evidence practice gap. So that's what, when we look about implementation science, it's an evidence practice gap. We have the evidence, but there's a practice gap. And this is, again, not just with palliative care, all across cancer, this is issues. The U.S. Preventative Care Task Force a few years ago tried to put out new guidelines for breast cancer screening, but they never talked to all the stakeholders that were relevant. And so all of a sudden this went out and there were a lot of people that were up in arms, right? So we need to take our stakeholder input into account. And so when we think about this, it takes a long time for original research to actually get implemented in practice, right? It takes about 17 years to transfer a small percentage of research into practice. And so how many things do we actually do? We pat ourselves on the back, we did a great study. Why is no one doing this, right? And people will talk about it. How many times people say, yeah, palliative care is great, right? We did a study a few years ago where we surveyed surgical oncology fellows across the country, right? And all surgical oncology fellows actually felt great about the idea of doing palliative care. They actually felt prepared to do palliative care, despite there actually being no palliative care education in surgical oncology fellowships, right? And so there's this huge gap here in terms of how do we translate this great evidence, still young, but great evidence into practice. And so, underlying how I got to this point was, again, the system is good as how we set it up, right? And so I always say, well, palliative care is great, but it's only as good as if we actually can use it. So how do we get folks to use it? And this leads to huge errors, right? And so with all these gaps, the Swiss cheese model of quality, there's all these gaps in the system, and how do we catch folks? How do we prevent them from getting harmed? We need to be thinking along the way of all these areas of cheese. How do we close the gap so people can get the care that's best for them? So I think, again, the future is now. Another Back to the Future reference. Every once in a while, things will pop up. You may see a sweet DeLorean coming down. So let's define some things. So implementation science. This is the study of methods to promote the integration of research, finding, evidence into healthcare policy and practice, right? This is underlying all that I'm doing right now. Pragmatic research. I think this is really important because often we think about research, we're going to have this very well-defined clinical trial. Well, there's a lot of issues in that. We don't live in a well-defined world, right? And so, again, bringing it back to other areas, I remember when I was in medical school and the oral hypoglycemics were coming out, but yet there were issues with African Americans taking some of the oral hypoglycemics because they called renal insufficiency and stuff. Why? Because they were not included in the clinical trials, right? So that's not really, it's a well-defined, well-done trial, but it's not a pragmatic. So we need to be thinking about that. Dissemination research is the study of targeted distribution of information and intervention materials to specific public health or clinical practice audience. And we need to understand how to best spread and sustain that knowledge. Implementation research is the study of the use of strategies to adopt and integrate evidence-based health interventions in the clinic and community settings, right? So I consider myself an implementation scientist because I'm trying to figure out how to take this evidence-based intervention, right, or evidence-based practice into practice. And underlying this, again, talking more, because I'm double down on this, and this is what I'm proposing to do in my future R1, is to really do a pragmatic trial to evaluate this in real world settings. Because the most common reason, again, evidence are not adopted is they're not seen as relevant, right? So it has to seem relevant to you. Why would I need to do this, right? This is a question I'm being asked. Why do we need to do palliative care in patients? Someone is not ready. Why is this intervention going to be relevant to me in my practice? That's something that we need to be considerate of at all times. So why is it important? Because again, evidence-based health intervention, we have to figure out, is it going to be adopted? Are providers, and providers is a broad thing, are they trained to deliver this care? How are they going to deliver it? Who are the patients that should be receiving it? And to what degree is access, engagement, quality, and sustainability exist? We need to be planning for this at the beginning of our studies, not at the end, after we already have our evidence of effectiveness. So putting it in context, we think about quality improvement. Some might say, well, this sounds like quality improvement a little bit. And there's certainly underlying, but the focus is different, right? The focus of quality improvement is more on, smaller groups of patients. As opposed to a practice overall. The goal of quality improvement is to fix a problem within a single healthcare system, often, not always, as opposed to generalizing to a healthcare quality and healthcare community overall. Both use design and trial strategies to improve the problem, and both use different models. So, these are theory-based, model-based of research on how to move forward with improving these care for all these patients, improving utilization of the evidence base. The bigger picture is this is an iterative process, right? So we've got some studies that show some benefit, and we've now developed an intervention to put that into practice. We're going to do some pilot studies, but we have to keep going over. So you see the corollary between quality and safety, right? Where we're this cycle of improving. Now we're going to show some efficacy, right, and or effectiveness of this, but then the underlying this is how do we get this to be used in the population overall? And so we need to be, again, considerate of all this when we're planning a study. One of the reasons I did my quality and safety certificate is because I think this underlies all that we're doing, right? And all of this goes hand in hand, and so we need to be cognizant of this when we're planning all of our studies. And what's important, I think, is that there's multiple levels of complexity to this, right? And so we think about it, one little thing is not going to make a difference, right? Education alone, we know that doesn't make a difference, right? And so we need to be thinking of the multiple levels of complexity. We need to be thinking about, is this scalable or sustainable? So in studies I'm looking to do, the scalability is important to me. When I talk to the NCI about the study, and it's like, well, and we'll talk a little bit more. So, how do you define this navigator? What kind of person is going to go out in the community and do this? Is it somebody that can be generalized, right? Is it adaptive to different situations? And so there's this idea of fidelity and adaptability in studies in the D&I research. That's something that I have to consider in my implementation and take the stakeholders at different institutions into account. And also respect for diverse approaches, right? So, Hospital X, they may want to do this a different way. And I learned from Peter Pronovost when he was here, I remember talking about the checklist. And he said, I go to these hospitals and people say, I've implemented a checklist, but it doesn't work. It's not working for me. And he says, you don't have to implement it the exact same way we did at Hopkins, right? There is room for adaptability in this, and one needs to consider that for their own microenvironment. So again, doubling down, even if something is 100% effective, it's only as good as how and whether it's adopted. And when we think of anything even being 50%, there's going to be a voltage drop over time, right? So, let's say you have one champion that's like really passionate about it. I love that person. And then all of a sudden they leave. You have the same processes in place, but you don't have that champion. And all of a sudden over time, less and less is being put into practice. And now the benefit is not fully realized as something that was completely effective, right? So it's something that we need to be considerate of. And again, look at all the levels that are here. So I'll talk about this a little bit later on, when I embarked on the study, I went to talk to everybody and their mother, right? Because Maryland's an interesting state. We have this whole kind of global budget. There was a Medicare Innovation Award. And so we have this thing called HSCRC. There's one person overall for the state that says, this is how things are going to go. So that was one of my stakeholders. I need to know if is this going to be effective and sustainable? How is this going to register for the Maryland population, right? I have to have my administrators from Johns Hopkins there with me in the room, vice presidents of the hospital, vice presidents of quality, and saying, like, is this something that's reasonable, and what is going to be a value added for you? What's the ROI for you doing what I'm looking to do? Because I have one thought as a researcher and as a clinician, but I don't know what you're thinking about. And then we're thinking about, again, departmental factors. So my oncology colleagues, I look at all the oncologists, but radiation and medical and surgical oncology, we are 3 different personalities completely. We're all cancer docs, but we're different personalities. Also, when I started the study when I was in Milwaukee, my mentor was a primary care doc. He said, what about the primary care physicians? And with rural Wisconsin, we're the ones providing palliative care. I didn't think about that because I had my blinders on, right? I'm an oncologist, and often we think we are now the patient's primary care provider when they're going through their cancer care, right? And so there's all these things that are in play, and at the core of this is a patient, right? So how do we bring all these things together? So dissemination doesn't occur spontaneously or naturally, and it's not passive diffusion. So we have to be very cognizant of, again, how are we going to disseminate something? But firstly, we have to understand the implementation. And as I've said multiple times, there's a reason for that. We need to be thinking about this at the beginning of the project, right? So what are the structures? So, what's your conceptual model? I've done a lot about thinking about, how is this going to be implemented, and what are the changes that I expect to occur? What are the processes? Well, it's important to engage those stakeholders, as we've spoke about, and I'm going to speak about again, because that's how important I think this is. What are the products that are expected? It's important for me to get from my stakeholders what the products they expect from this, and make sure I'm measuring that, right? So if they don't see those byproducts, they won't be grounded in this. So if I left and this is working, if the vice president of the hospital, president of the hospital, doesn't see any value added after I've left because I'm not there to push it along, then that's going to be dead in the water, no matter how effective this is. And then we need to consider the system changes, right? What kind of shifts need to occur, if any, to make this a priority and a reality. So what's needed? Well, at the base of this, and this is from Kim Johnston at Duke's work, when we think about, especially from a disparity standpoint, there are multiple gaps in the research, right? And I highlight the things that I'm looking to do in my study. Certainly, the experience of caregivers, I think, is really important. There's a lot of work now going on with caregivers, and that's, when folks are sick, right, we all know this, those caregivers' experiences are really important. So in my study, we're recruiting everybody as a dyad, right? The caregiver and the patient is recruited as a dyad because it's important for us. But we need to be developing and testing interventions to see how are we going to improve this care overall. And it needs to be prospective and longitudinal studies, right? So, doing a one-off retrospective review is not going to change anything. And also, as we talked about, this measurement of patient, provider, health system, organizational variables is really important. What are the balancing measures? What is the process measures bringing back to quality and safety that's going to ground this intervention to help us in the future? Overall, this means we need system and population needs assessment, model selection and matching to the population needs, right? And so this is where this theory comes in and helps us think about how do we implement this. Then we need to have a system integration design, right? So in the studies we talked about, I'm recruiting multiple hospitals, but Johns Hopkins, we have multiple hospitals. One is 2 miles away. Johns Hopkins East Campus and Johns Hopkins Bayview are 2 different places. So what do I need at those? And that doesn't even account for community hospitals that I'm recruiting into the study, right? And then looking at implementation, quality, and standardization overall. So there has to be some fidelity but adaptability built into any study. Clearly needs to be workforce training, and then at the end of this is going to be public and constituency awareness. So, one of my friends and mentors is Dory Segev. Dory Segev has like 5 R01s. He's met with every president. He's gotten he's a transplant surgeon that has taken his research and translated that into advocacy, right? And one of the reasons I had as one of my stakeholders, the head of the state medical board, is I'm looking to advocate at the beginning of my study. Right? This is something I'm building in to how I'm doing my research. And so for me, my overall research objectives are to increase palliative and hospice utilization individually or by specialist palliative care, by physicians caring for patients with advanced malignancies, and evaluate models of care, as we said earlier on, to best improve utilization. My focus, my goal is on African Americans with advanced solid malignancies. Again, a multimodality, multi-level approach, I think, is extremely important. And by using novel techniques, may it be a stakeholder engagement and looking at implementation of this intervention, which is patient navigation, I'm hoping to really find an effective way to improve palliative care. So my approach is to use a navigator, right? So a navigator, and in this instance, is a community health worker to focus on barriers to quality palliative care. So navigators have been used for many years, and their jobs within their job scope is this elimination of breakdown in communications. They help significantly with decisional support, and that's what I'm focused on, both advocacy and activation, right? So some patients don't need you to advocate for them, but they need some of the words to communicate. They need maybe sometimes a booster, right? They need to say like, hey, this is what you need to say. The doctor's not listening to you. When we did our stakeholder engagement, one of my patients who is a 30-year breast cancer survivor who now has non-small cell lung cancer, who's on immunotherapy, said, I'm having chest pain. And got a CT scan and her tumor hadn't progressed. Said, great, it's not the cancer, but I'm still having this chest pain, right? So she comes back over and over to her visits, and no one addressed her symptoms. It's not when you're 78 years old, that's a real thing, right? Chest pain is a real thing. It wasn't MI, but she had costochondritis, guys. This is not difficult stuff, but it wasn't being addressed, right? And certainly coordination of care. Patient navigators, community health workers, they coordinate care for patients, especially in the outpatient setting. So this is all based on theory, right? The social cognitive behavioral theory, looking at self-efficacy, modeling of health behaviors, and behavioral capability. So this is the underpinning of what we're doing and what we're hoping that a community health worker will do. And so this is kind of the conceptual model that we've looked at. We're going to take this environment in both the healthcare and the external environment that's at play, and we know that this is a major issue for patients, and underlying that is the patient and physician characteristics. We're going to implement as community health worker downstream from that, and again, hope that they will advocate and activate patients to obtain palliative care, right? They'll be communicating with physicians and working together, hopefully to increase the use of palliative care and advanced care communication, hopefully again leading downstream to patient-centered care and delivery of care implementation. I think it's important we go a little bit into patient navigation. And so patient navigation is this, again, patient-centric delivery model, and it looks at movement of patients along the continuum of medical care. And it includes many steps, right? They go into the community, and they've been doing this for a long time. So patient navigation has worked to improve testing, right? So patients who have a CHW navigator are more likely to get colonoscopies, pap smears, prostate testing, right? They're more likely, they have improved diagnoses. So when this first started, this was started in Harlem, because Harlem Hospital, because the surgeon there said, my patients are dying of breast cancer, as opposed to across the city, and patients were living longer, right? And I'm from New York, and so I know the rates of breast cancer in Long Island and in the city are very high, but people were dying from breast cancer in Harlem. And so by implementing this, a group of patients who were, of individuals who were usually lay health workers, right? They were able to improve survival and increase screening for these patients. And ultimately, it's been used to improve disparities across the continuum of care. So we started in cancer, but in cardiac care, HIV, sexually transmitted diseases, have all been helped by using a healthcare worker or navigator. And this works because they're addressing all these barriers, right? We're looking at screening, we're looking at treatment, education, emotional support, and outreach. Again, this is even within one group. We talked about this multi-level care, right? Multi-level care is already occurring with one individual working with patients. So I thought that there was a need. I thought it would be reasonable that patient navigation is fundamentally about transitions of care. Palliative care is fundamentally about transition of care. I thought they actually went hand in hand. I was sitting in a room and trying to figure out what to write for my K when I was in fellowship, and I was like, wow, this could work. It's like with peanut butter and chocolate, right? So it's a comprehensive means of addressing barriers, right? So we're about the economic barriers to care. So I can't go to my appointments sometime, right? Because I got to worry about my lights. When I lived in Milwaukee, we had a great hospital in Freighter in Medical College, Wisconsin. But if you lived on the other side of the city and you didn't have transportation to get to the hospital, that was it. I had patients that lived further away, and we had Badger Care in Wisconsin. Badger Care didn't show up sometime, the bus to bring you to the hospital. Cultural, we know that certainly there's religious underpinning, right, within a lot of this. And again, is there cultural competency in how we communicate with our patients? Again, we as a medical workforce, there's a lack of time, right? Even if I spend 45 minutes, I'll leave the room and my nurse practitioner is like, "What have you been?" When she goes in, I'm trying to look for her. She's like, "Well, they had a lot more questions." And I was patting myself on the back and thought I did a great job, right? And they're social, right? So there's knowledge gaps, both from patients and clinicians. And I think we're actually the biggest issue more than the patients, right? Because they often know what they want. They just need us to help them say it. So we did a systematic review and said, well, is this something that's reasonable? Or is there a signal here? And we looked at cancer navigation for cancer treatment, not screening and diagnosis, but treatment, and palliative care and hospice use. And we found very low levels of actually navigation for treatment. And there was only 2 studies looking at palliative navigation. And this is, many of you know, Stacy Fisher and Gene Quintner in Colorado. They're doing navigation for their Hispanic patients in Denver, right? That's it. There's just us and them in Colorado, right? So they have shown effectiveness, and they now have an R01 to study this as well. But for curative intent patients, we found that when they had more contact with navigators. So if you're curative intent, that's great. But what about if you're not curative intent, right? What else can we do for you? And we know that in at least the Stacy Fisher studies, it led to fewer missed appointments and improved advanced care planning, pain management, and goals of care discussion. So there is a signal there. That's a kind of that's an itch to be scratched. And so what I did is I said, you know, as my first aim in my K is I need to talk to all these people and get them in a room. And so what we did is we had a stakeholder engagement. Well, what's stakeholder engagement? Think about it as a focus group with everybody that's involved along the continuum of care, right? And so as opposed to saying, you know, we want males 18 to 35 or 45, which is that great TV demographic. We want, you know, everyone that loves to watch Murphy Brown's coming out. Everyone that wants to watch Murphy Brown, right? And these are people that are influenced the implementations or decisions that are involved in research. And the reason that this is important, because this is now then taking research that addresses questions that are relevant to everyone, right? Patients, physicians, healthcare decision makers. So we put them all in a room, right? And we asked about, you know, we first said, let's define palliative care. How do you define palliative care, right? Well, as you can imagine, the definition, even by a healthcare provider, was very variable, right? And so once we got past that, then we could really discuss, hey, a community health worker is somebody that we think could be useful. Please tell us, how do you think that could be useful? And what are the barriers and what are the drivers to that? And we use that for evidence that we think is difficult to implement it in practice, right? So palliative care is kind of difficult to implement in practice in many hospitals. Everybody's working great. This is like a mecca here. This is like, you know, everybody drinking the mead, or but everywhere else, we don't have that, right? So we need to map that process. We need to say, really upstream, what are the issues? and what are the leverage points that we need to focus on to help change. And so, again, this is beneficial because I feel like my stakeholders who are following me through my studies help me structure my intervention, right? Every time I come back, I'm doing any work, I'm bringing it back to my stakeholders and say, you know, is there a signal here? This is reasonable. It enhances the commitment to the study. They're involved in my study along the way. So the head of the HRCRC from Maryland, I speak to her twice a year. Say, hey, here's what we're doing. What do you think about that? Again, it enhances implementations of the findings, and it, you know, hopefully will increase sustainability and certainly transparency. And so, again, these are just a smattering of the folks that are involved in there, in this, and certainly, you know, there are folks that I don't have social work. My wife's a social work, and she would kill me that I have my social workers off here, but social workers were also involved in this. And so when we did this, we came up with this, you know, this is qualitative work where we had them sit down. We came up with this, the structure, and we said, these are the most important things for folks, right? So there's this idea of the hub of the wheel, that this community health worker could help us obtain resources. They could provide patient and caregiver support. This is what they do. They could provide some psychosocial report just by modeling and being there for patients. And certainly the folks that I've hired, they're all comfortable with this idea of discussing spirituality, because many of us probably go to church, but we walk into a room and our religion is left outside. Often that's what occurs, right? And so, you know, some people really want that. Or it's the ability to say, as palliative care already does, either as a CHW, I'm going to refer you to the chaplain that can be useful to you, right? There's systemic factors. So this whole idea of conflating hospice and palliative care, you know, if the physician doesn't know how to describe it, and when you're in a meeting and you don't even feel comfortable talking about it, at least there's someone that can start titrating this message of palliative care with you. And this is big into this idea, this titration, message redundancy, titration, right? So my CHWs meet with these patients every time they have an appointment. They can go to their homes or anywhere that they choose and discuss, hey, how are things going, right? And again, allows folks to process over time, because often we're waiting to the end to even discuss any of this, right? And again, we believe, and we're seeing some signal that's improving patient-provider relationships. We have built into our Epic communication between our CHW. So my CHW will then write a note to the oncologist, say, hey, I spoke to Mrs. McGillicuddy. She thinks you're great. She thinks that, you know, there's an issue that you're having, that we're couching these things, right? Because we want to make sure that the physician doesn't feel like, one, what is this person doing? But two, that, you know, they're part of the team, right? And so we're kind of bridging that disconnect and empowering greater communication. At the center of this, again, is the patient and caregivers, their providers, and the community health worker. So what can we do? What are we going to measure from this? So, you know, we're looking to study this process. So we're starting to pilot this and applying our best professional knowledge and engaging a full team that we think works. And look at how do we think the process will change, right? So we're looking at outcome measures, certain ones, but we're also looking at process measures, right? This is really important from a quality standpoint, and balancing measures. What are the issues that occur? If I do this, what if this happens? When we need to look at that in our own, each microenvironment, to make sure that that when we go to an MGH, that's it, we can say, here are the issues that are at play. You need to look out for this. So again, our community health workers now going out, and their role is again to address barriers to high quality palliative care. They're using education, support, and patient activation to do this. And our navigators, our CHWs, are involved with the study development, right? So we have actually a nice group of patient navigators, CHWs at Hopkins, and I've invited many of them. There are two that run their program that are my stakeholders, and they're very helpful for me. These are folks that have been in the community for decades, right? And understand the landscape, not just at Johns Hopkins, but understand the landscape in the city of Baltimore that are able to help guide us. Underlying this is training, right? So if our navigators were hired through a program. So in the post-Freddie Gray era, hospitals said, we need to hire and provide jobs for our citizens. And so these are folks that were underemployed, who are here now, and one of the jobs they have is community health workers. So they needed training, right? Not just to be community health workers, but to say, what is palliative care, right? What's a MOLS? What's a PULSE? What's an advanced care plan, right? What is even this idea of a goals of care conversation, right? How does religion play with this? And so we created a structured program for all of our individuals where they had 2 weeks of training in class with didactics and with role playing. And then they were embedded in our hospice program in Baltimore, and they also rounded with our palliative care service. Also, their office is at the palliative care docs. There's no reason to be with me. What am I going to do? They sit there I'm being practical. They sit there with our palliative care docs. Why? This is hard stuff. We all know this. You all decompress together. When they have a question, certainly you can ask me. But if you have a nurse practitioner who is the grounding for them, that you can discuss some of the issues you have with discussion of patient, we've seen that it goes a long way for them. And at Duke, they tried to do this community health worker, just an advanced care plan. And one of the reduxes was, we feel very overwhelmed with this idea of doing this. And so by providing this support, we are finding, at least with our CHWs, they're feeling a strong sense of a family, right? A strong sense of support to be able to do this. And so again, the navigators had this is a smattering of this, but disparities context training, say, well, why do you have to do cultural competency of disparities? Well, everyone's not a monolith. We don't have the same experience, right? So we need to understand how to have these conversations, even if you're a Black person talking to a Black person. This is a different thing. Obviously, medical center, there are resources. They have their booklet, as any community health worker does, and where are my resources? And they're building those up, and they're working together to get the things that I didn't even know existed. And even palliative care docs in the city didn't even know. We've gone to every hospice, because Maryland is a certificate of need state, right? And so we know we have a set number of hospices. We reached out to everyone, and we said, tell me all the resources that you have for patients, both in hospice. Do you have a transition program? What can you do? So we know if you're coming to Hopkins, but you live in Eastern Shore, we know what hospice is there. We know what they can offer you, right? And so maybe it's, I hand you off to them, and you don't need much from me. Maybe I still need to be checking in on a regular basis, but again, it's this idea of titration. Again, they now understand Maryland law with the advanced care planning, this whole idea of myths and misconceptions. We talked about, this misconceptions about a chemotherapy, the patient needs an operation, the whole idea of opening the air, spread, and the cancer spreading. We've talked about all these things because I think it's very relevant. And again, obviously, knowledge of hospice, what's the financial coverages that are there. Obviously, they don't need to know all this. They need to know, hey, I'm hearing this signal. I need to transition you to my social worker, right? And we're an interesting place because, certainly we have the social workers in the cancer center, but if you live, again, in Eastern Shore, you live in Columbia, who are the folks that are available? How can we link them? So again, it's providing these resources on a more global level. So currently we're field testing this, right? So we're doing our pilot testing and looking at our visit protocol, refusal rates and strategies to minimize dropout, because I think it's important, bringing larger trial to see what are the issues. Certainly, as is any palliative care study, we've had people recruited that have died that weren't expected to die from their oncologist, right? But we're testing our data collection methods. There's a lot of patient-reported outcomes I'd like to get, right? But, when you're feeling ill, you don't want to talk about all this. Right? You don't want to go through all the things. So what are the important things we want to capture? And ultimately, again, evaluating the navigator from the patient and caregiver side and from the clinician side. A little overview of kind of what we're doing. And again, we're looking at this, doubling down this, we're studying the process, we're looking at the outcome measures, the process measures. This is some of the things we're looking. So we are powering a larger study looking at how many advanced care plans. We want to transition that from, we have that evidence, right? It's in Epic, but not just, do you have an advanced care plan in the medical record? That's great, but we all know, yeah, I have an advanced care plan. It's in my safety deposit box. Yeah, I have one. Myrtle died 2 years ago. She was, on my power of attorney. So we have all those information. We're looking at pain. We know that pain is really important. We talked about the costochondritis, right? But there's larger pain. We know that many patients with cancer die in pain. We want to prevent that. Ultimately, we want to increase the use of hospice utilization and utilizing hospice further up front, right? And overall, again, looking at patient-reported outcomes from the patient family satisfaction, quality of life, mood, and symptom intensity. This is all leading to my R1 that I'm working on right now to send to NCI and titled Decide PC, looking at dissemination implementation based community health worker intervention for disparities in palliative care. And it's based upon this conceptual model, right? So this is I'm a WashU graduate. I love WashU. This is Nola Proctor. She's very well known in the, she's a social worker. My wife did social work school with her and at WashU. And so, but she is a major player in the world of implementation science. And so, you know, this is the theory-based mechanism looking at, we have an intervention strategy to improve evidence-based practice. We need to look at implementation strategies and how to implement that. And when doing that, we're going to look at certain outcomes. We have our implementation outcomes, right? Aim 3, specific aim 3 with the R. We'll look at our service outcomes, specific aim 2, right? And we'll look at our clinical outcomes, specific aim number 1, right? And so we're looking at all of that, and hopefully we're going to bridge the gap by, again, closing that evidence to practice gap. And looking at the implementation strategies, I think, is really key. We're now in the process of bringing that back. And so we use some of these theories that a student can't go into implementation sciences this morning, but we've used these theories to, again, go back to our stakeholders, analyzing focus groups to say, okay, here are the most important intervention strategies that we've noticed from talking to you. What do you think is the most important, ranking those? Because we can't have a CHW do everything under the sun, right? That's not realistic. And so our paper is submitted now to JPM, and looking at that and saying, okay, here are what we think is more important. We're assessing that currently and go from there. Again, we're looking at the differential on all these 3 outcomes. And again, there's this intermediate outcome, right? This, that's important. What's the acceptability of the intervention? Is this a worthy goal overall? This is a multi-level implementation strategy. This is how these things have to work. You have the we have what's going on with the CHW themselves, but also we're looking at, what changes need to happen from a system standpoint, what changes needs to happen from just in my clinic standpoint. We're trying to make those a low burden for everyone. So ultimately, I think what I hope to find is that we've improved quality for these patients. We've improved patient satisfaction. One of my administrators said, that's what's important to me, right? If you increase our HCAP scores, that's going to be great, right? It's a very practical answer, right? As part of that is a simple thing. I think every hospital I've been at, I used to do quality and safety, the communication about medications has been poor, right? So if you know that here are drugs that we can get for these patients and get them in a better way, that's going to help us, right? A cost effectiveness. We know, like I was told by the head of HRCSC, don't talk about costs. Don't talk about costs. Why? Because then you start getting a slippery slope of death panels, right? But on the undergirding this, we're talking about resource utilization too, right? So less resource utilization will lead to improved cost. We hope to improve disparities, certainly to improve the sustainability. If this is not effective, we will certainly still have learned how to improve, how to go through this process and test models over and over, right? Scalability is going to be, we're going to be evaluating that. Again, sustainability and implementation. And so weave this narrative, I hope, a little bit about kind of where I started, what we're doing now, and what I'm hoping to do in the future. And I look forward to hopefully changing the lives of these individuals and closing this gap of quality and disparities for some of the most vulnerable populations that we have. So again, I thank you all for the opportunity to be here, and please don't hesitate to @ me on Twitter or email me if there are any questions.
Thank you so much, Dr. Johnston. We'll open it up for questions, and maybe I'll start by, I'm so curious about how you're recruiting these community health workers. I know certainly globally, community health workers, at least in low and middle income countries, are the backbone of palliative care, but at least I'm not familiar with working with community health workers, so I'm wondering if these are often people who have a background of they themselves are cancer survivors, or if it's the general public, and then also what has been the reaction of providers to interacting with these community health workers.
So thanks for that question. So the recruitment is a standardized recruitment, but interestingly, when I interviewed these individuals, they all said the same thing. I helped nurse so-and-so through this, right? I was the caregiver for that. And we asked these pointed questions, right? We asked about, how do you feel about, these discussions? I learned a lot through PSEP, through having, responding to emotions, and we model that. Right. And so, we talk about, are you okay with dealing with that? Yes. And we're often trying to put these kitty gloves, but these folks have lived more life than many of us have lived, right? That I'm recruiting. And so certainly they have to be okay with it. But we have a cadre of people that are actually very well prepared to do this work. We just need to support them through it. And the response has been, I think, very good. Overall, so yeah.
Other questions?
Thank you very much, Dr. Johnston. Excellent, talk. I'm very impressed. My question is, can you elaborate a little bit more about sustainability? How do you actually measure and how do you demonstrate sustainability from your project?
So the honest answer is sustainability is going to be is downstream, right? So right now, this R that we're planning to put in is looking at implementation and effectiveness. If we're planning everything or we're cognizant of the issues that could prevent sustainability at the forefront, the goal is that will translate into sustainability down the line. So even this idea of stakeholder engagement research, that alone, engaging your stakeholders translates into sustainable processes. But to answer you more specifically, these process measures are important, right? And so by saying what are the important process measures, so that we can measure those along the way, that will give us a signal. Say, well, is this continuing along in the way that we expect it to? So it's again, the sustainability is part of it is what's important to us and what are those measures that are going to be relevant. And so certainly it's, part of it is how often are the CHWs seen with the patient, right? So when are you closing down this case, right? And from there to if they enter into hospice, right? So what's that gap? Is it actually helping? So that's one example of looking at that sustainability. But where the sustainability is going to be measured more down the line. Right now, we just need to show, we know that community health workers are effective. We know that palliative care is effective. We don't know that bringing them together is going to be effective. So we need to first primarily look at the effectiveness of this, right? Measure the implementation. And then if we find that, yeah, this is good, there's going to be another trial down the line. So, when Vicki and I were talking this morning, this R, my hope is that my next R is, if God willing, I get it, that the next R is 3-4 years down the line, doing a larger scale study, going through, NCORE through the NCI, going in community hospitals, which provide most of the cancer care in this country, to study this mechanism.
Fabian, I love this stuff, Take me through, though, the community health workers. Who are they actually docking in with? Because I get they're getting all this training. That's super helpful. The reality is, and I can see, I'm looking at Julia Gallagher, thinking about our home-based models and all these things that we do, and who is the right role group. But who are they docking in with to say, this is what's going on with the patient, and this is what my care plan is going to be in some way? And how does that dock back in with whoever the cancer team is?
So right now, we have the community health worker that's overall, and we have one of our palliative care nurse practitioners, right? Okay. And so they are working with them so that if it's an issue that may be relevant, and the email goes to both, or the communication both, if it's real relevant to getting resources that a CHW needs, they have somebody to lean back on. But certainly, the nurse NP serves almost as a care management coordinator as well. Right now, as we're going through this, and so sorry, I know we're talking later on, but we're still figuring that out.
Yeah.
Right? Like,
and what's the role of a social worker in that? Because one could imagine that there could be community health workers who'd be docking up to a social worker and potentially a nurse practitioner. It feels like part of what this is important work is that we're trying to understand really what's in the syringe and who is best to be docking in to make sure that the CHW is getting what they need.
So part of this is, so that's a great question, right? And to be honest with you, part of this is just my microenvironment, right? So, I as a surgeon, so Hopkins is a weird place. I as a surgeon who has a cancer patient, if my patient's not getting chemotherapy, I can't send them to the social worker at the cancer center. Right? Wait a minute, say that again. So I cannot get social work for my cancer patients at the cancer center if they're not getting chemotherapy at the big house, right? And so that's my microenvironment. And so I spend a lot of time talking to everybody. My wife's a social worker, and she's had arguments in the car with me and said, why is the social worker not involved? And I literally have to say, this is where I am. So at the other hospitals that we were talking to, that's going to be what happens, right? But we have to, again, that's where that adaptiveness occurs, right? So we just have to work within what we have.
Want to open it up for questions at our remote sites? No questions from the virtual audience?
There was one question up there. Oh, I thought you had one.
Maybe for the sake of time, we will close there, but allow people to come up and speak with you. Thank you, Fabian.
Okay, perfect. Thank you.